Greetings and welcome to another and final program for the week of Saskia Unreserved. In the studio today we have the eminent psychiatrists, and I say two because the other one is on his way. This is Dr. George Mikellides, and Dr. Lampros Samartzis is on his way, and he's going to come. And we're going to be discussing fetal alcohol syndrome and another very important subject, harm reduction approach. So if you have any questions about drugs, fetal alcohol syndrome, and you want to know more about what it is, do stay tuned, post your comments, and of course we're looking forward to having them answered by our very eminent guests.
So thank you for inviting us, Saskia, I suppose.
Great. We're crossing over now.
I'll probably have to repeat that.
Unfortunately, we had to make quite a lot of shouting to the ministry, but eventually we made it and
managed it.
He's coming. So anyway, we're happy to have you here. And we've just heard the first two movements of the Sinfonia Concertante by Mozart. I have a time check for you for 1:45. A reminder, you're tuned into a RIC Classic 88.2, and we're also going live on Facebook. So if you are anywhere near the computer or Facebook, log in, and we're going to be discussing with my special guests today two very important subjects: fetal alcohol syndrome and the approach of harm reduction approach to drug use. My special guest, Dr. George Mikellides, already here in the studio, and Dr. Lampros Samartzis on his way from Athalassa Psychiatric Hospital. A very warm welcome. Thank you for being here on the program.
Thank you, Saskia, for inviting us.
If you can just go a little closer there to the microphone, that's great. And I'd like to begin, before Dr. Samartzis is here in the studio with us, to talk about something that's an event that's happening tomorrow, and that is at Alexander the Great in Paphos.
Yes, that's right. We've got basically a presentation on smart ideas on longevity, as well as how to stimulate the brain. This is in terms being organized by Fetal, which is a charity organization mainly on dementia and Alzheimer's disease. And there will be tickets available. I think most of them have been sold, but perhaps there's still some available. The tickets are for 10 euros, I think. Obviously, the money goes to charity on dementia, to Fetal. And it's going to be a Christmas party to kind of celebrate with people living with dementia and their carers. So perhaps everyone is invited to come and join us to see the presentation, attend the Bazaragi on Christmas celebration, and people can buy stuff and be there at 4 o'clock tomorrow at Alexander the Great Beach Hotel.
So there are going to be different things for people to buy, and I'm sure food as well.
I think so, yeah. I think there's going to be food as well.
You mentioned the carers. It's very important to actually pay attention to the carers, sometimes maybe even more so, I might add, than the person who's actually suffering from dementia, because of the strain of what they're going through.
We do see high levels of anxiety and depression among carers. So what we tend to say as health professionals, that when someone is affected with dementia, basically two people are affected, the carer and the patient. You should always bear in mind that the carer is taking on a lot, and there's always the burden of managing someone's behavior who is suffering from dementia. So we need to look into that as well, assess the carers and support them.
Do you believe that we've actually made progress? We're nearly at the end of the year now. Do you believe that we've made any sort of progress with regard to awareness, at least, of Alzheimer's and of dementia?
I think that we have done a good work this year, and we have promoted dementia through different events in terms of prevention and diagnosis and treatment, and we have done a good work in terms of organizing an event for health professionals and for carers and for patients on dementia. That was a few months ago, as you remember.
Yes.
So I think we should carry on the good work in terms of informing the people in Cyprus that dementia is in front of us. People are living longer. If you go back like 150 years ago, they used to live up to the age of 40.
Yes.
Now 62% will live up to the age of 80. So people are living longer, and we need to find ways to manage the difficulties, the problems, the dementia that comes along.
The awareness is there. Has the stigma been reduced in any way?
The stigma, if we look into it and think about it, because we all have like parents or grandparents living with dementia, has changed. The thing is sometimes that people should be aware that people suffering with dementia usually are managed by neurologists, psychiatrists, geriatricians, and each professional have their own expertise. So it's very important to think that if your person who you love suffers with dementia and needs to see a psychiatrist, there's nothing wrong with seeing a psychiatrist. That doesn't mean your loved one is crazy or anything like that, but you need to be aware that the psychiatrists are the ones to manage the behavior that comes along with dementia. And sometimes also the whole pack, but what we tend to do is we liaise with different doctors, and we kind of like look into managing the symptoms and the behavior that comes along with dementia.
As far as individual places are concerned, in each of the cities in Cyprus, so across the 5 cities, is there an equal, are there equal facilities for people suffering from dementia? No,
of course they're not, and there are issues around that, and there should be in every city, in every district, different things, such as like memory clinic. We have started a year ago now in Nicosia. It should be in every district, not just in Nicosia, because not people only in Nicosia suffer from dementia.
I was going to say.
So it's important to start initiating memory clinics in every district in Cyprus.
Is the memory clinic, sorry to interrupt you, is that run by the government?
Yeah, I was the one that organized the memory clinic for the last 1 year in Gendro Lacha, basically.
And now that you're going and
someone
you're leaving,
someone else is going to take on that, and hopefully within the next few months, a memory clinic will start in Limassol as well. So there is a doctor being identified who is going to run the clinic, the memory clinic in Limassol. So hopefully that will happen soon in the next few months.
Right. Has this been factored into? Hello, Dr. Samartzis. Thank you so much for coming. I will be with you in a minute. I just want to ask Dr. Mikellides, as far as the YESI is concerned, how is this going to affect the clinics? Surely they factored in now that they've got such a brilliant plan in place, that they need to have so much allocated for these clinics, and we're going to see them all springing up and everything is going to be perfect.
So nobody really knows, I think. So things are in the pipeline, things are changing, things are being organized. That's what we hear in the last few years. But we haven't seen anything to grab on that as clinicians. We're not quite clear as what is going to happen. It's all down to the OKP, how is that going to organize the things, and who is going to be the providers, who is going to be paid. We hear about pay by results, we hear different things. how things will work around, but as we all know, doctors have not agreed yet in terms of ESC plan, etc. So we're not quite clear as what's going to happen.
It boggles the mind that 6 months prior to the launch, we are still...
but the launch actually is happening in January. It's not in 6 months. So things are changing in January.
In January.
In terms of primary care. And people don't really know how will that work. So we'll see.
That's a whole other subject. Our subject today, and thankfully after quite a lot of... a few telephone calls, we've managed to get Dr. Lampros Samartzis here as well. So thank you. Please just speak very clearly into the microphone. To speak about fetal alcohol syndrome. And I wanted to start by asking, are all psychiatrists in agreement with what it actually is?
Is a well-known syndrome that comes as a result of alcohol overconsumption during the pregnancy, the period of pregnancy. Alcohol overconsumption by a pregnant woman. The result is, of course, there are some symptoms to the newborn, to the baby.
Yes.
Not exactly to the baby, but after some. Usually, the common presentation is that the newborn is doesn't show any signs initially, but later, some years later, during the preschool or the school period, elementary school period, first years of the elementary school, the child presents some symptoms that is something like attention deficit hyperactivity disorder.
Yes.
So some symptoms of decreased ability to follow the class.
It's very interesting that it's actually called fetal alcohol syndrome, because it's something that actually manifests and becomes apparent only quite a bit later.
But actually, is what we see as what we should say. It's a lifelong disorder. So it's not just in preschool or in school. If we've got people like suffering with concentration difficulties, with let's say aggressive behaviors, impulsive behaviors, difficulties in schooling, problems with the law, things come into play that actually the person will live with this syndrome for the rest of his life or her life.
And as psychiatrists, how do you actually go back and think, this could be alcohol fetal syndrome? It could be as a result of it. Because if you have attention deficit disorder, how do you know that what it's being caused by?
This is true. It's sometimes is not that easy to set retrospectively diagnosis of the syndrome. Of course, this is something that in the very severe cases we can diagnose from the very first days.
Right.
Because there are some phenotypical symptoms, signs.
Yes.
In the for example, in the face of the newborn, also in the face. But these are only severe cases. Usually, there is everything looks like that. There's no problem.
A small head as well.
Yeah. Small head, small, very thin upper lip, big, increased distance between the upper lip and the nose.
Yes.
The nose.
There's some faults around the eyes, there's some differences in the ears.
Right. So there are actual physical differences as well as the learning disabilities and the intellectual disabilities. How is that different to PFAS, so partial fetal alcohol syndrome?
Well, the
Okay.
partial is the full is the symptom who shows all these signs and symptoms. The partial, the partial syndrome usually doesn't include the physical manifestations, but includes some of the manifestations of the
Okay.
So for example, some irritability, irritability, you cannot quantify the irritability. So
No.
some people talk about severe or mild irritability.
Yes.
So obviously if we talk about the full-blown fetal alcohol syndrome, then we can see like a severe agitation, severe symptoms. So which is when it's partially, obviously things are affected, but as not severe as we see in the FAS.
As a woman and as a mother, I cannot understand how this has even happened. It's incomprehensible that it's a syndrome that can actually be totally avoided by not drinking in pregnancy.
That's true.
So I mean, it's not just alcohol, as I mentioned before we have started today.
Yes.
It's smoking cigarettes, it's drug use, dangerous behaviors, and in any way that you're actually putting yourself and your baby at risk, basically.
So, yes, but does it have the same results? If you smoke, it doesn't mean that you're going to possibly give your baby fetal alcohol syndrome.
Obviously not. FAS, I think, is much more severe and much more
Yes.
important. Take into consideration if you're going to try and compare the two.
Yes.
But both of them are equally bad in some ways.
Very.
Yeah, of course.
Yes. Is there any treatment? Is it reversible, the damage that's done?
Some of these manifestations may become reversible by using behavioral approach and treatment during the schooling years. But unfortunately, some is not totally reversible.
Like obviously the physical manifestations, the head. If a baby's born with a small head, does it go back to a normal size later, or it's not
very
possible?
hard to say impossible, really. It's nothing impossible in human life.
Of course, yes.
But it's very hard for this to change.
All right. How much alcohol are we talking about? I mean, obviously, it's best to say
No alcohol.
no alcohol at all.
There are no specific guidelines to say how much of alcohol is actually safe. Sometimes we hear gynecologists advising, you can drink a glass of wine per week or something like that.
One a week. A glass a week.
But actually this is not based on any real evidence, so it's not in literature. We don't see what amount of alcohol is considered safe in pregnancy. So most of us, I think, we should advise that we should not drink any alcohol during pregnancy.
I can't. It's very difficult to understand how anybody would actually jeopardize their pregnancy or their child and be left with so many difficulties afterwards. What is the situation in Cyprus? Do we have a large number of patients suffering?
Unfortunately, there are no released statistics on this. And this is sometimes, as I said before, these children are delivered totally normal with an APGAR score 10 to 10 or 9 to 10, so almost totally healthy.
Yes.
They don't show the full-blown syndrome with the physical phenotypical symptomatology, and therefore, and later during the preschool or elementary school period, they show this sign of academic or psychological development retardation.
And then I guess by the time a child is 6, it's very difficult to go back and say to the mother, well, were you drinking during pregnancy?
Now it is all pregnant women are asked during the pregnancy and having counseling regarding the alcohol consumption, and they are suggested to avoid any alcohol consumption during pregnancy, or if they are already suffer from dependency or the alcohol use disorder or addiction to alcohol, they are suggested to start a treatment on this.
Yes.
So in order to avoid, at least during the pregnancy period, to any alcohol consumption, or if they cannot avoid any alcohol consumption, as George said, some doctors suggest one unit of alcohol, a glass of wine or a beer during a week, not more, or one or two. So this is a harm reduction approach.
Yes.
If you cannot avoid at all the total, if you cannot have a total abstinence,
Okay.
then
When the baby's
at
born,
least only one.
when the baby's born, is it actually suffering from withdrawal symptoms?
Of course. Like it's the same thing as well when people use heroin. You actually see irritable babies, problems with feeding, problems with diarrhea. So you can actually see these symptoms in the newborn, especially when we're talking about FAST, the fetal alcohol syndrome. So they're quite there, and pediatricians are probably the ones that will investigate them and provide treatment to their newborns.
Why? All right, let me go a little further. Is this not actually a criminal offense?
Well, that's a tough one there, number. But I suppose it's a harm. You're actually harming your baby. Who's going to take it to the court?
Because it's actually
about,
avoidable.
Yeah, I suppose they can prosecute you, probably.
What they do usually is if someone is having a behavior that could harm the baby or the embryo, a social worker can take a role in this, in the management of this, as a part of the multidisciplinary team who manages this.
But no one is going to take you to the court unless you do
Yes.
something really, really bad.
In the UK, there was a court case 2 years ago, and the mother was found to be not accountable.
But there is negligence. So
but
there is negligence, and not just negligence, there is harm. You're actually causing a harm. Obviously, a lot of people talk about the fetal, the embryo, and the rights of the embryo might not be there.
I was going to say that was we go into a whole
Ethical
legal
and legal stuff, yeah.
subject there as far as that's concerned.
And then you think about abortions as well. Until what age, how many weeks the mother is allowed to actually have an abortion, because there is a limit there as well. And
Yes.
in Cyprus, it has been the case in the last year or so that a gynecologist, I think, was prosecuted because he did an abortion to a lady that basically is still illegal. They were trying to pass a bill, I think, through the parliament.
I think it was passed.
Was it passed?
Yes, I think. I stand to be corrected, but I think
Yeah.
it was passed through.
I'm not sure if they
up to a
passed it, but they
certain
were thinking
age.
about it.
I would like to add another point in this discussion. If the mother is a non-addicted alcohol abuser, then you can say that contributes to harm to the embryo. But if there is an addicted or a dependent, then it's considered a patient, because addiction is a chronic relapsing limiting mental
yes.
disorder. Then we can say that it's not something that he does intentionally.
Yes.
Of course, he has the obligation to start the treatment and to avoid, to protect the embryo.
Dr. Mikellides touched on drugs as well, and having the syndrome. I'd like to ask about caffeine and its effects, not only during pregnancy, but also while breastfeeding.
So, I suppose caffeine is a mild stimulant, and I should go back to the ancient Greeks and say everything in moderation. So if you're abusing a stimulant, then obviously it will cause irritability to the newborn, to the baby, and also to the mother. So they can use also decaffeinated coffee, which is another option for people they love coffee, and drink in moderation. Some gynecologists will advise as well 1 coffee per day, and that's it. So just going back to the phrase everything in moderation, I think that will be the optimum.
Right. Something which is also equally difficult to understand is harm reduction approach. And I wanted to bring this up as well today. And maybe you can outline to our listeners, Dr. Samartzis, what it actually means.
I'll try to describe in a few words. When we say harm reduction, harm reduction is a treatment approach, treatment philosophy, that a modern treatment approach in order to treat drug addiction comes as something like a step further from the old one, abstinence-oriented approach, total abstinence-oriented approach, or
Yes.
the war on drugs approach. This says that we prefer, it is better for our patient to avoid any use of illegal drugs, of drugs of abuse, legal or illegal. It's better to avoid at all. But if he doesn't want or he cannot avoid at all, to avoid totally avoid the use of these drugs of abuse, then we can still offer him care and treatment in order to help him to stay alive, to increase his or her quality of life, and to increase the life expectancy.
All
And to
right.
avoid to decrease morbidity and mortality of this patient. So we continue to care and to offer him treatment, despite the fact that he doesn't stay away from drugs, but he continues
Yes.
to do some use of drugs of abuse.
So my question is, why should we be sanctioning this use of drugs? Because what you're actually saying is, I assume that it's something similar to what they have in the Netherlands, where there's a clinic and you have a bed there and some needles and a drip or whatever drugs are of your choice, and then at least people are happy because you're using a clean drug, clean needles, instead of at least throwing them around. And
Safer.
it's safer, yes, but why should the taxpayer, because basically the taxpayer is providing this, why should we be doing that? And
Yes.
why should we not be saying that this is not okay? And where is Cyprus in harm reduction approach?
There are some, this harm reduction approach, of course, is a pan-European or universal approach, is one of the pillars of the European drug policy guidelines. Of course, and there have been some steps in this direction starting from 2007, when the opioid substitution treatment approach started in Cyprus. Opioid substitution treatment approach is treatment that is
So this type of approach has been in place in Cyprus since
Yes.
2007.
since 2007, and we are
It's a
Okay.
bit late.
a little bit late because other countries, for example, the Great Britain, or Germany, or the Netherlands, as you said,
Yes,
or
other European
other
countries.
European countries,
Yes.
have more or less 40 years since they started this,
And-
and Greece 25 years.
All right, let's
So
go to the results of Greece, if you're familiar with those in particular. Has it seen a decline?
well, this
Or that isn't the purpose?
In Greece, I'm going to tell you, in Greece and Cyprus, unfortunately, especially in Cyprus, we don't have yet the full frame, the full all the full range of services. Of course, we during last 10 years we did some progress on this field, and we have a very good indices compared to the average of the EU member states.
Yes.
In drug use and and deaths from drugs and morbidity and mortality from drugs. We are in a good, we have good results, less than the European average.
Okay.
Despite the fact that we don't have yet the full range of services. We have this opioid substitution treatment, and for example, we don't have yet this, as we said before, the drug consumption rooms or other services, as for example, the heroin-assisted treatment, heroin replacement treatment approach.
I never bring religion into discussions. But because...
That's a good thing.
Yes, I think so. But I'm going to make an exception in this case because we're in a state controlled by religion, and I think that it's a pertinent question in a place where we can't actually even be buried in the way we want. So how is it that we can sanction drug use? Because in a way, we're sanctioning drug use.
I suppose it's a debate that you can talk about it forever. So there are people, there are professionals, health professionals, they will advocate for legalize and regulate.
Yes.
Rather than the way things are now, which is a big mess basically. In Netherlands...
in which way are they a mess?
Okay, there were different things, like sometimes trying to manage addiction with an addictive drug, for example.
Right. It doesn't work.
It doesn't work. Like OxyContin, there was a huge thing in Cyprus that basically you cannot use OxyContin for substitution therapy because it's addictive, creates a tolerance, and it's not licensed or approved for it. So until recently that has stopped.
So was that
Cyprus.
actually being prescribed?
There are some well, opioids is a family, a category of drugs that you can use in, they have indications for the pain, medical use, they have medical use,
Yes.
legal, good medical use as painkillers, for example, and bad illegal use as recreational drugs of abuse.
So how has Cyprus...
Sometimes there is a diversion.
Yes.
You can obtain an opioid medication for medical use, but you can use it. You can change the indication. You can
you can do anything you like in
yes.
Cyprus, basically,
Yes.
Saskia, if you don't know that.
And change the use and use it as an illegal, as a recreational drug. This is something that is a worldwide phenomenon. For example, you can take you can have prescribed you can take a legal opioid painkiller. You can change the form from pill to powder. You smash it. You make a water solution.
You can inject it, you can inhale it, you can do what you like.
Inhale it or inject it, yes. You can use it as a recreational drug of abuse. And of course this includes...
and then obviously that's something that you've maybe prescribed.
No, I didn't prescribe.
No, but I mean it could be prescribed by...
You could prescribe, are we talking about which substance?
Well, whatever you've just said, that's...
This is common to the pain management.
To pain management drugs.
You obtain painkillers and you use it as a drugs of
euphoria,
as a recreational for recreational reasons, or in order to self-treat withdrawal symptoms if you are already addicted to other opioids. So this is called diversion. You change the indication or the way you use or the route of administration, or you sell illegally.
So in Cyprus, we seem to have not progressed to where we need to go.
I think we should not be so kind of like negative, I would say, Saskia. I think we're doing work. Things are changing, probably not in the best way, but in a good way, let's say. Well, in a good way.
All right. Tell me how we can go so that it can be in the best way, considering that other countries, as you say, have started this 40 years ago. Is this the ultimate solution? What is keeping Cyprus back?
I think one of the important things is setting standards. As we know, for example, in the UK, they've got the CQCs, the Care Quality Commissions, but they're looking into what is the best care, something we don't have in Cyprus. So these are the committees, actually, they look into everything to do with health. It is to do with drug substitution, to do with mental health, to do with cancer care, to do with dementia. So when you're running a clinic, either in the public health sector or in the private sector, you should be meeting standards, and someone should be regulating you.
And the someone regulating you is now...
And an independent body as well.
There we go.
Which does not exist, obviously.
So we don't have an independent body. So that's what's stopping, for example, us having a neurosurgeon in the Bafos Hospital or in Larnaca. I was absolutely flabbergasted to find out that we don't have a surgeon in these hospitals.
Because
so if you have any kind of head trauma, you've got a serious problem until they get you to Nicosia.
Because when you actually, everything is run through the ministry, then ministry, as we say in the Greek language, I am the dad, I'm the godfather. So I do what I like. So an independent body will be able to do some other stuff.
How? What is the feeling of doctors about such a body, and has it been put forward to the ministry?
Look, of course, this is a good thing to progress in by having an independent body for medical guidelines and protocols, etc. And this I think that is going to take place soon. I would like to add to the discussion that is also a matter of money, a matter of funding, because drug addiction is a chronic mental disorder that it is treated as a part of the mental health sector, in the mental health sector, private or public sector mainly.
How many patients have we got who would fall into this category of harm, using the harm reduction approach, who are not prepared to stop using drugs?
This is of course it is considered that there are more or less 1,000 of high risk IV drug abusers in Cyprus, and 1 every 5 of them is already under treatment in the public health sector by using a harm reduction approach. Of course, there are others who are treated in other treatment centers.
I just want to focus on the ones with this harm reduction approach. Have you seen that it's made positive steps for them? Has it actually helped?
Yes, they are helped. This is clearly they are clearly helped by avoiding any criminal offences, any morbidity, hospitalizations, any unnecessary visits to the.
These are all things that actually cost
to avoid
the state money.
Increase functionality.
Yes.
They go back to work, to the family. There are some economical studies on this that there is evidence that for every €1 you give in order to develop harm reduction services, the state takes back around 12 or 15 euros. So it's a very good way to spend money.
Right.
That's
a very important factor that you've actually brought up.
To invest, yeah.
To invest. And this is what we have way. It's very important to invest in these things, in these services, taking into account that the money that goes for mental health in Cyprus is very, very low. Is more or less 4% of the
GDP.
of the of, for 3% of the GDP is the total health
Right.
expenditure for the whole specialties. For mental health is around 4% of the money of
It's
the
a fragment.
It's a fragment of the 4%.
More or less 20 millions of the 580 millions of the
Right.
Ministry of Health. We take only 20 million, so it's very low. We have to increase this, and taking into comparing with so only 4% of the public health expenditure goes
Yes.
to mental health sector, and for example in the United Kingdom NHS is around 11. So 11% of the NHS is the NHS mental health. So we have to go from
We've got
4%
big
to
steps.
11. So we have to make a big step of 7% of the increase of the total
Who's
health
going to give
expenditure.
the money when, as we hear the ministry talks, that basically there is no more money to be given?
In
as we
order
have
to
heard.
increase the quality and the services offered.
Exactly. And I just want to mention something, Saskia, which
Yes.
is very important, I think, for everyone to hear, because you have said something earlier about the taxpayers
Yes.
and about providing services for people that they are suffering with addictions. As Lampros said earlier as well, and as what the WHO talks about, and the International Classification of Diseases,
Yes.
addiction, it is a mental disorder. And it's the same thing as having an addiction to alcohol, as having a diabetes, for example. So you should be treated. Which way you are going to be treated, that is something that the professionals will decide based on literature, based on evidence. And harm reduction is the way that we're moving towards a new era of managing addiction. And we need to take into consideration as well what the patients
Yes.
want and what the wishes are.
I think they seem to be very far down on the list in terms of considering them. They're referred to as bingers, as junkies,
and et cetera.
outcasts, the social evils, and I think that there's a lack of compassion
Empathy.
and empathy shown towards these people. And I think that very few in the public sector, and I don't mean the public sector working, I mean the general public, understand that it is actually an addiction.
Mhm.
This
And it needs treatment.
stigmatization to
Yes.
this subgroup of patients, this population subgroup of the addicted patients,
Yes.
the patients who are suffering from drug use disorder or alcohol use disorder. This is the correct medical terminology. So this stigmatization makes them to stay away from the treatment, to avoid going to the hospital, and to stay untreated.
I can only think that if you say to somebody, okay, you need to abstain today not today, for the next whatever period of time, from something that they really like. So whether it's reading or it's eating or talking to their children, pretend that you can't do that for the next hour. And let's see how somebody can actually react to that. I always think of being addicted in that way and how one can actually stop.
We can see actually people that are addicted, we can see their functional MRIs, that we can see that the way the brains are wired are not the same with someone who's not addicted to something, and we can see that these things could change through time, through therapy, even through counseling, through proper treatment with medications. We can think, and we can see that addiction can be given a new way of managing addiction. We can fight addiction, and we should not think that for some of these patients it might be a long-term disorder. It might be a lifelong disorder. For some, it could be a way to get out of that. And either way, you can still have a family, you can still have a job. It doesn't mean if you're addicted to something, you cannot function. You can still have a family, you can still manage to keep up with a job. If you're seeing the professionals, if you're getting the treatment, we've got patients, we see with Lampros that they're taking Suboxone, for example, which is a substitution therapy for heroin and opioids. And we can see these people going to work, having children, having families. So it does not mean that if you're addicted in a substance that you're completely off your social life.
You've mentioned substitutes do those substitutes have the same effect as heroin?
They have this substitute is a class of opioid medication. For example, first generation was methadone, second generation buprenorphine, third generation combination of buprenorphine and naloxone, and fourth generation diacetylmorphine or DAM. Unfortunately, we don't have yet all this range of medication available. Now we have only one of them. We are going currently in the near future. We plan to obtain and to use also the other treatments, starting from methadone and then going to DAM, diacetylmorphine, according to European clinical experience and guidance. This medication, as George said before, you can have a treatment and increase your functionality even without total abstinence from illegal drugs of abuse. So, for example, people who is addicted to an illegal substance, they can, after treatment or during the treatment, he may increase his functionality in the family, in the job, or the social environment.
Yes.
Social environment, his interpersonal relationships, and to function better, go back to work, return to his family, etc. Even without stopping the medication, the drug, the illegal drug. But of course, he has to be under treatment. He has to change the way he uses this drug to decrease the frequency and the dose.
This is different, though, to be under psychiatric care and therapy, as what I've understood from the places, for example, in Holland, where nobody actually says anything to you. The places there open for you to go and use clean needles and whatever. There's a difference.
Someone needs to supervise those places.
Are those places? So those places are supervised.
Sometimes they could be supervised by nurses or social workers or doctors, depending on which place we're looking into. Ultimately, is who is responsible for that place. Because imagine, Saskia, if someone dies in that room with an overdose.
Yes, that's what I wanted to ask.
So who's going to have that responsibility? Obviously, a multidisciplinary team managing a place as such, it will be the best practice.
I'm going to. This is a very modern approach. Now there is currently currently around Europe there are working 90 of these
facilities,
these rooms in main cities around Europe. This is called drug consumption rooms, actually. Drug consumption rooms is a place when you can go. Usually there is a health professional, not necessarily a psychiatrist. It may be a social worker or a nurse, or and they offer the drug consumption. You bring your own drugs. Your own drugs.
Okay.
And they offered a safe place to use the drugs, and they are offering clean needles and syringes in order to avoid the drug and syringe sharing, which is something very, very risky for
AIDS and
hepatitis C,
HIV, and other viral infections. In order to avoid this infection, the transmission. This is the word. To avoid the transmission of these viral infections in the society and the population, and also in order to avoid accidental overdoses. Because if you have an accidental overdose and you are alone in the forest or outside of the city, maybe the user will die and nobody find him before 5 or 4 days. And if you are in drug consumption room and you have an accidental overdose, they can give you the antidote immediately, that is naloxone, an antidote, and you immediately,
Be safe.
or you can go, or you can transfer you to the emergency department of the hospital. So we avoid deaths from drugs, and this is very important. And now the reason why we focus on the opioids is because that 90% of the deaths from drugs are a subpopulation of the drug user, that is the young men who use IV opioids intravenously. This is 90% of the drugs. So if we avoid drugs in this subpopulation, the
Yes.
opioid addicted people, then we decrease for 90% the deaths from drugs per year in the country. So this is called harm reduction.
I want to bring up human rights, and when you talk about these drug consumption rooms, do you think that is a place where somebody might go out to try drugs for the first time, and is it sort of giving somebody the stamp of allowance of saying that it's something acceptable? And
You cannot buy their drugs, or you cannot deal. Drug dealing is not legal. It's still illegal. It's not a legalization of.
It's not a legalization, but it's a sort of acceptance, in a way, of being able to do it. And maybe if one person's going to go and do drugs, they'll take their friend along who maybe doesn't do it out of curiosity, and they go to have a look. Now I'm thinking in Cyprus, and they may even try. And I'm thinking in Cyprus, before you came, Dr. Samartzis, we were talking about Alzheimer's patients, and that we don't even have a clinic for these patients in each city.
Mm-hmm. That's true.
How are you going to say that we're channeling funds into harm reduction approach and to having these kind of approaches to taking drugs?
Of course, this is something that, to my viewpoint, both of these services are
They're both necessary.
Both necessary for our health system. It's a different. One is for the drug, for the this is
There are
for different
just
category of patients.
a whole lot more people suffering from dementia, I think, and Alzheimer's than the 1,000 patients that you've said. But equally, I can negate my own argument by saying, well, there are fewer people having to deal with multiple sclerosis, but it doesn't mean that it isn't debilitating, and that those, even if there are 3 people in the whole of Cyprus suffering, that they shouldn't be.
You should provide care.
They should have care, of course.
Obviously, the government should provide care for every patient. It's a duty. It's
Yes.
a human right to be alive and to have the best possible care. So I think we're learning, we're growing, we are trying to get into the European guidelines for everything, as Lampros mentioned about the European guidelines on
Yes.
drugs, the European guidelines on everything really, and there are also the WHO guidelines. So obviously everything comes down to money and how you're managing it.
How does the health ministry, what is their approach to these drug consumption rooms?
We don't have yet one of them. I don't know the opinion of the Minister of Health for this. I think that this is something that we discuss in the service, and probably in the near future we can.
You have actually discussed it with the minister?
Not with the minister, but between psychiatrists and in the multidisciplinary team, and
Yes.
during drug policy meetings we discuss on this.
And what is the
We
approach?
We know that it's very good to have the full to all the available treatments to be all the full range of treatments for drug abuse to be available for the Cypriot patient, to have the availability of all range of services and treatments, and some of them are the harm reduction treatments, harm reduction services. These are the opioid substitution treatment, as I said, that is available still since 10 or 11 years ago in Cyprus, starting from 2007. Drug consumption rooms are not available yet. Now we have a program that is going to start from this year to provide with a self-used antidote the drug users, naloxone intranasal naloxone kit. So if they see if they are going to suspect an overdose, then they can use and to invert the overdose by themselves, because sometimes there is no time to.
You can see sometimes
is that injectable?
No, just intranasal through the nose.
Intranasal. Okay.
So you can see that sometimes even in like the American police officers, they might carry that in their cars, like having that kit within them, because sometimes you can't get passed by an overdose, which you have few minutes to save someone's life, and if you have that kit, as Lampros was saying, in your car, you might be able to save that person.
If we have
There's
it
no time to transfer the patient
for dog poisoning,
doctor.
we can definitely have it for humans.
And I think something which is very important we haven't touched today, and we're probably running out of time soon.
A little bit, but yes, tell it.
I think it's like you've got the right to treatment when we're talking about addictions. No family member, no one is actually going to force you to get treatment for your addiction. No one can do that.
As you've said on previous programs, it's always down to the person themselves.
Exactly.
Because you still have the right of no treatment.
Exactly.
You can.
If you have the capacity to decide for yourself, that comes down to that.
Sometimes, though, I can imagine. I've never been in this situation, so it's very hard for me to understand what it must be like being in the family of a drug abuser.
You can just say something very simple sometimes, just to understand addiction, and then we can move that. That's horrible. That's a disaster. Because I hear stories every day which are really horrendous about breaking stuff, threatening with knives, threatening with guns, and you name it. You hear it as a psychiatrist.
Yes.
That does not mean that you're going to lock up someone in a mental health hospital because of these behaviors. Asking for money, for example, threatening to kill to obtain cocaine, right? But what I just want to say, it's obviously.
I understand that, but tell me about the person who's on the receiving end of that. How do they deal with that?
It's a disaster. They should go through court proceedings and obtain restraining orders against their own children. That's what they should do, rather than calling up psychiatrists, telling them lock them up in a mental health hospital.
Oh, is that what happens?
Yeah, exactly.
So you believe that the restraining order is going to work?
Of course, if they will obtain one, but they will say it's my child. I cannot do that. I cannot send my own child to prison. Sometimes people do that because indirectly they might stop using drugs, not by forcing them upon, let's say, a medical treatment, but by kind of like putting them into prisons.
But nobody can actually force. It's not the way it is in the movies anymore to have someone sectioned off.
No, you section people based on mental disorders that are treatable, and they lose capacity because of them. They're not able to decide for themselves, and they become dangerous to themselves or to others.
But that's not done by family members.
They can ask through the court proceedings to be examined by psychiatrists, but comes down to the psychiatrist to decide if that person should be sectioned to a Thalassa hospital for treatment. As we have described, there is no treatment to make someone stop using drugs. If you lock them up for 3 days or for 3 months, they will walk out and carry on doing drugs. That's what we see every day for years. So people need to realize that if the person does not want to obtain treatment, then they will not. And it's not down to psychiatrists and health professionals to lock them up and force them to take Suboxone, for example, or take something else so they can stop using drugs.
So the solution is the availability, to increase the availability and the accessibility of free or low-cost services for the patients, in order to go by themselves on a voluntary basis to start the treatment, not to lock them in a room or something.
Do you have these dilemmas where you're actually asked to do these kind of things?
Every day, shouting at you, being blackmailed. If that person does something to my family, that person is probably their son or their daughter,
Yes.
or whatever. Then you will be reliable and you'll be held liable to get into court proceedings and stuff.
And when
Dr.
we-
George,
when-
who helps those people?
Who? The families.
Yes.
They can seek. Probably they will be suffering from some sort of anxiety disorder as well, or depression if they go through this for months with their own children. So first of all, they should get treatment for themselves if they're suffering from a mental disorder.
Yes.
They might need to see a psychologist. They might need to see a therapist. They might need to get into family therapy if that person wants to get into family therapy as well. Because
Yes.
what we tend to see, obviously, those families are having a lot of issues between the family members in terms of communications, for example, in terms of childhood abuse. We do see a lot of drug users that they have been abused in childhood by their own parents. So it could be emotional abuse. Sometimes emotional abuse is much worse than physical abuse.
Oh, yes.
So you need to get into family therapy if that person wants to get into family therapy.
Do you see a lot of these cases,
Yes,
Dr.
and I would like to,
Samartzis?
of course, everyday clinical work, we see many of these cases. And we'd like to add that when we are thinking about the family problems regarding addiction in a family member,
Yes.
of course, this is not only the some rare or some illegal substances of abuse, as for example heroin or cocaine or other. There is also illegal substances like alcohol, and there are also some behavioral addictions, as the gambling, that
Destroys homes.
that can
Yes.
destroy and can have
An effect in your
the
life.
same disastrous
Definitely.
effect for the family.
We're going to be discussing that in 2019. We have some comments on our Facebook feed. Addiction is self-treatment, and each sector has an obligation, and allergies should also be screened very well, is another comment.
Addiction is using illegal substances in order to self-treat mental health problems. This is what.
It does happen.
Yes.
It does happen. Sometimes we
Very
see
common,
our patients suffering from schizophrenia. They might trying to use cannabis so they can calm down the voices, or drink alcohol so they can calm down the voices. Obviously, those self-treatments are not good enough and are not based on any
I
evidence.
think
there is
what she
another-
was trying to actually say is that, as on the point of you're saying that nobody can actually force somebody to get help. The person has to want help themselves in order to fix this.
Sometimes,
yes.
usually, this is very common, a person starts using a substance for recreational reasons, occasionally for
Yeah.
recreational reasons, then and continues this behavior when he is non-addicted. Then when he becomes dependent,
Yes.
he cannot stop because he is suffering from withdrawal symptomatology when he tries to stop. So therefore
Psychological sometimes withdrawal symptoms.
Yes.
So therefore then continues to use the drug not for recreational reasons as in the past, but now he has to use it in order to self-treat withdrawal symptoms. So he cannot perform without the medication. So that's why some people start drinking alcohol from the early morning.
There's Christmas coming up now, and while it's a festive, so-called festive period for many it's the dreaded festival, and they can't bear it. They can't bear the lack of family unity. They're alone. Many have to work. It's a sad period. Many people have lost others. There's a lot of flow of alcohol, an incredible amount, and I'd like your opinion on this festival as psychiatrists.
You said a lot already. I think
Sorry.
you kind of cover the subject.
I always think of it as the dreaded festival because I think of so many people who are so unhappy
Yeah, it brings up memories from
Yes.
the past, childhood abuse,
Mm.
childhood difficulties, comparing yourself with other children. I didn't get any presents. My neighbors used to have a better house, better decoration. The Santa used to come to my neighbor's house. Santa didn't used to come to mine.
Yes.
But there's always this kind of, as you said, some people have lost relatives in this period. So there's always a sad period for some. But on the other hand, it's a festive season as well. For some, or most of us, we kind of trying to celebrate in some ways. But yeah, you're right. There's always the.
What advice do you have to give those who feel that it's a sort of dark period? And additionally, in Cyprus we're lucky because we have quite still a long number of hours where it's light.
I think that a good suggestion is to suggest people to avoid staying alone this period, and it's a good opportunity to see this celebration, the Christmas and the New Year's Eve celebration, as an opportunity to rebuild and strengthen the relationships with family members.
Yes.
And important others, friends.
Right. What about
If you have
giving?
any.
Of course.
What about?
Because sometimes people don't have relatives, don't have friends,
Yes.
which makes things impossible.
This is the person I
This
was.
is why this is a risky period for lonely persons,
Yes.
even for suicide attempts.
This is what I was going to say. I for example, know one
It's very
person.
traumatic to spend all these days alone.
She's very alone, and I thought it's always good if you can possibly donate your services and do some volunteer work. But somebody who's really depressed doesn't even want to volunteer or help.
It depends on what level of depression we're talking about. I mean, if you're mildly depressed, you can try and push yourself as much as you can. In any level, you can try and
Yes.
push yourself as much as you can. But I think what's important is to try and, as Lampros said, is to try and get into different kind of social interactions
Yes.
rather than isolate yourself.
Right.
Isolation makes things worse because you always comes down to social comparison. You'll be thinking, oh, Saskia is out with her parents drinking wine. Obviously, we're talking about wine
Yes.
now, but everything in moderation. So
Yes.
celebrating, and I'm at home alone. So if you're thinking about all this kind of social comparison theory, you'll get into trouble. You get into melancholia. You'll get into depression.
Facebook is bad for that too.
Yeah, because you might have so many friends and you don't talk to anyone. So and you don't know anyone. I don't know.
Yes. It's been a pleasure to have you both here on the program. Again, thank you so much for coming in, and I'd like to wish you and your family.
You're about to say something. He was about to say something.
Thank you very much, Saskia, for the opportunity to discuss on this
And
important
we'll be back in the new year with a whole lot of new subjects, and I hope that everyone has a healthy and happy Christmas. We're still
Thank you,
here.
Saskia.
Thank you very much.
Rick Classic 88.2. It's 10 minutes to 2. And let's listen to this last movement of the Sinfonia Concertante by Mozart.